presentation is major obstetric hemorrhage. Shall I start, sir?
Yeah, please go ahead.
Nikhil, can you keep your video on, please?
Yes, sir.
Yeah.
We can see your face. Go ahead.
My topic of presentation is major obstetric hemorrhage. Obstetric hemorrhage is world's leading cause of maternal mortality. As the major obstetric hemorrhage complicates up to 10% of all births. In India, obstetric hemorrhage contributes to 22% of all maternal deaths. Obstetric hemorrhage can be classified as antepartum hemorrhage and postpartum hemorrhage. Antepartum hemorrhage is defined as bleeding from vagina after 24 weeks of gestation till delivery, and postpartum hemorrhage can be defined as blood loss within 24 hours of delivery, which is more than 500 ml following vaginal delivery and more than 1000 ml following cesarean section. Antepartum hemorrhage includes common causes. Common causes of antepartum hemorrhage are placenta previa, placental abruption, uterine rupture, and vasa previa. First, we will see placenta previa. Placenta previa is present when placenta implants in advance of the fetal presenting part, and incidences of placenta previa is approximately 1 in 200 pregnancies. Placenta previa is classified in three types: total placenta previa, which completely covers the cervical os; partial placenta previa, in which placenta covers part but not all of the cervical os; and in marginal placenta previa, placenta lies close to within 2 centimeter but does not cover the cervical os. Etiology of the placenta previa is advancing maternal age, multiparity, multifetal gestations, prior cesarean delivery, smoking, prior placenta previa. The most characteristic event in placenta previa is painless hemorrhage. This usually occurs near the end of or after the second trimester. The initial bleeding is rarely so profuse as to prove fatal, but it usually ceases spontaneously, only to recur. Placenta previa may be associated with placenta accreta, placenta increta, or placenta percreta. Coagulopathy is rare in placenta previa. Diagnosis of placenta previa should always be suspected in women with uterine bleeding during later half of pregnancy. Appropriate evaluation should be done, including sonography. Examination of cervix is never permissible unless the woman is in operating room with all the preparations for immediate cesarean delivery, because even the gentlest examination of this sort can cause torrential hemorrhage. Safest method is transabdominal sonography. MRI can be done. Obstetric management in placenta previa is generally expectant management and surgical management. Vaginal examinations are best avoided, and if needed, should be done under double setup examination. Anesthetic management in placenta previa. Firstly, for double setup examination, which is rarely performed and only performed in operating room, full preparation for cesarean section, which includes maternal monitors, insertion of 2 large gauge intravenous cannula, administration of non-particulate antacid, sterile preparation and draping of the abdomen, and 2 units of packed red blood cell should be ready. For cesarean section, which is the choice of anesthetic technique, depends on indication and urgency of cesarean section and degree of maternal hypovolemia. High risk of intraoperative blood loss will be due to 3 reasons. Obstetrician may cut the placenta during uterine incision. Second would be lower uterine segment implantation site does not contract well, and third would be increased risk of placenta accreta. Preoperative preparation for placenta previa pregnancies is patient evaluation, resuscitation, and preparation for operative delivery all proceed simultaneously, and careful assessment of parturient's airway and intravascular volume should be done. 2 large gauge intravenous catheters, 4 units of packed red blood cells, and blood administration set and fluid warmer should be ready. If needed, invasive monitoring equipment should be kept ready. Rapid sequence induction of general anesthesia is the preferred technique. Propofol should not be used in hypovolemic patients. Ketamine and etomidate are the good alternatives. Ketamine with 0.5 to 1 milligram per kg of dose and etomidate 0.3 milligram per kg of the dose are best induction agents for bleeding patients. Patients with severe hypovolemic shock, intubation may require only with muscle relaxant, without induction agent. Maintenance of anesthesia, nitrous oxide and oxygen with low concentration of volatile halogenated agent. Concentration of nitrous oxide can be reduced or omitted in cases of fetal distress. Oxytocin 20 units immediately after delivery in 1 liter of NS or RL should be given. Low uterine segment implantation site does not contract well as the fundus does not contract. All uterine relaxant should be eliminated if bleeding continues, and best to eliminate the volatile halogenated agent after delivery. Substitute can be used for volatile agent is nitrous oxide 70% and intravenous opioid. Second is placental abruption. Placental abruption is defined as the separation of placenta from decidua basalis before the delivery of fetus. Risk factors of abruptio placenta are hypertension, advanced stage and parity, tobacco use, cocaine use, trauma, premature rupture of membranes, history of previous abruption. Presentation of abruptio placenta are vaginal bleeding, uterine tenderness, increased uterine activity, and complications are hemorrhagic shock, acute renal failure, coagulopathy, disseminated intravascular coagulation, fetal distress or demise. Obstetric management of abruptio placenta will be definitive treatment is the delivery of fetus and placenta. If degree of abruption is minimal and the fetus shows no sign of distress and maternal hemodynamics are stable, then we can hospitalize the patient, monitor fetal heart rate, serial ultrasonography should be done, and maternal hemodynamic monitoring should be done. And after the fetal lung maturation, we can do the delivery. Anesthetic management of abruptio placenta, in which preoperative preparation should be done with airway assessment, assessment of volume status of the assessment of maternal volume status, maternal hemodynamic monitoring, fetal heart rate monitoring, and 2 large bore IV catheters should be placed. Blood for cross matching and hematocrit and coagulation, and maintain supplemental oxygenation. For labor and normal delivery, epidural analgesia can be given only if coagulation studies are normal and no intravascular volume deficit is there. In case of cesarean section, general anesthesia is preferred for most of the cases. Regional anesthesia can be given for patient with stable hemodynamics, good intravascular volume, minor abruption, and no fetal distress. Ketamine and etomidate are inducing agents of choice. Rapid sequence induction is preferred. Large doses of ketamine may increase the uterine tone during early gestation. So doses of ketamine should be limited to single dose of 1 milligram per kg. Aggressive volume resuscitation with both crystalloids and colloids should be done. Blood transfusion should be done. Central venous catheter and arterial catheter may be necessary. High risk for uterine atony and coagulopathy. Oxytocin 20 units per liter infused immediately after delivery. And coagulation abnormalities may require FFP. In these cases, patient recover quickly and completely after delivery. Prolonged hypertension, coagulopathy, and massive blood volume product replacement are best monitored in multidisciplinary intensive care unit. Third is uterine rupture. Rupture of gravid uterus can be disastrous to both mother and fetus. It may be of 2 types: uterine scar dehiscence, complete uterine rupture. In scar dehiscence, fetal distress is less common. No excessive hemorrhage, rarely requires emergency section. In uterine rupture, fetal distress is present, massive hemorrhage is there, and requires emergency cesarean section. Causes of uterine rupture are previous uterine surgery or trauma to uterus, which is indirect or direct. Indirect trauma is blunt trauma, excessive manual fundal pressure, or extension of cervical laceration. Direct trauma is penetrating wound, intrauterine manipulation, forces application and rotation, postpartum curettage. grand multiparity, uterine anomaly, placenta percreta are the causes of uterine rupture. In uterine rupture, patient presents with vaginal bleeding, hypotension, cessation of labor, and fetal distress. Obstetric management should be uterine repair, uterine artery ligation, and definitive treatment is hysterectomy. Anesthetic management of uterine rupture is preoperative evaluation, resuscitation, and preparation of OT should be done simultaneously. GA is often required. Regional anesthesia can be given in hemodynamically stable patients who already have epidural catheter and absence of fetal distress. Aggressive volume replacement should be done. Maintenance of urine output should be done, and invasive hemodynamic monitoring would be necessary. Fourth is vasa previa. Vasa previa is associated with velamentous insertion of cord where fetal vessels traverse the fetal membranes ahead of the fetal presenting part, in which there is no threat to mother, and there is highest fetal mortality in these cases, 50 to 75%. Early diagnosis and treatment are essential to reduce the chance of fetal death. Requires immediate delivery by cesarean section. Neonatal resuscitation and neonatal volume replacement should be done, and choice of anesthetic technique depends on the urgency of cesarean section. Now, second is postpartum hemorrhage. Major cause of morbidity and mortality is the postpartum hemorrhage. There are two types of postpartum hemorrhage: primary postpartum and secondary postpartum. Primary postpartum hemorrhage occurs during the first 24 hours of delivery, and secondary postpartum hemorrhage occurs between 24 hours to 6 weeks postpartum. Causes of postpartum hemorrhages are uterine atony, genital trauma, coagulopathy, and placental abnormalities. First, we'll see uterine atony. Uterine atony risk factors are multiple gestation, macrosomia, polyhydramnios, high parity, chorioamniotis, precipitous labor, augmented labor, and tocolytic agent. Oxytocin is the first line drug for the prophylaxis or treatment of uterine atony. Endogenous oxytocin is produced by the posterior pituitary. Exogenous form is synthetic preparation. 20 units of oxytocin to 1 liter of NS or RL started as an infusion. Bolus administration of oxytocin causes peripheral vasodilation and hypotension. Cardiovascular changes are short-lived, less than 10 minutes. Misoprostol 800 to 1000 microgram rectally, prostaglandin E1 analog, and carboprost preferred for the treatment of refractory uterine atony. 200 microgram administered intramuscularly or intramyometrically. Second is genital trauma. Most common injuries at childbirth are lacerations and hematomas of the perineum, vagina, and cervix. Pelvic hematomas are of three types: vaginal, vulval, and retroperitoneal. Signs and symptoms of genital trauma are restlessness, lower abdominal pain, tender mass above the inguinal ligament, vaginal bleeding, abrupt hypotension, urinary retention, and hematuria. Anesthetic management of genital trauma. For vulval hematomas and small laceration, local infiltration and small doses of intravenous opioid. For extensive laceration and vaginal hematomas, a pudendal nerve block can be used, but technically that is not feasible, and neuroaxial blockade may cause hypotension. Monitor anesthesia care is most preferred technique for extensive laceration and vaginal hematomas, with nitrous oxide oxygen with inhalational agent and low dose ketamine. For retroperitoneal hematoma, laparotomy with general anesthesia and rapid sequence induction should be done. In this case, difficult intubation should be anticipated. Retained placental products are leading cause for both early and delayed postpartum hemorrhage. Obstetric management for retained placental product is manual removal and inspection of the placenta. After removal of the placenta, uterine tone should be enhanced with oxytocin. Anesthetic management of retained placental product If epidural catheter is in situ, additional local anesthetic drug can be given. Subarachnoid block can be given if patient is hemodynamically stable. Nitrous oxide analgesia can be given. Low dose ketamine can be used. General anesthesia can be given with rapid sequence induction, and other methods to facilitate uterine relaxation are halogenated inhalational agents and nitroglycerin. Uh, Next is placenta accreta. Placenta accreta vera is defined as adherence to the myometrium without invasion of or passage through the uterine muscle. Placenta increta represents invasion of the myometrium, and placenta percreta includes invasion of the uterine serosa or other pelvic structures. Risk factors are previous uterine trauma, previous cesarean section, low-lying placenta. Diagnosis of placenta accreta is done antepartum diagnosis, which is very rare, and difficulty in removal of placenta. Ultrasonography can be used, MRI can be used, and transvaginal color Doppler also used. Obstetric management of placenta accreta is uterine curettage followed by oversieving of the bleeding placental blade, balloon occlusion, embolization technique, and postpartum hysterectomy is the definitive treatment. Anesthetic management of placenta accreta is preoperative diagnosis of placental abnormalities, identifying patients with high risk of placenta accreta, and preparation for hysterectomy. Availability of blood product should be ready. Uterine in fourth cause is uterine inversion. Turning inside out of all or part of uterus is uterine inversion. Risk factors of uterine inversion are uterine atony, inappropriate fundal pressure, umbilical cord traction, uterine anomalies, and abnormal implanted placenta, like placenta accreta. Obstetric management of uterine inversion is early replacement of the uterus. Once the uterus has been replaced, oxytocin 20 units per liter should be infused initially, and additional drugs may be needed. Anesthetic management of uterine inversion is uterine tone precludes immediate replacement. So uterine relaxation is needed before successful replacement can be performed. Ideal technique should have rapid uterine relaxation, no side effect, short duration, and restoration of uterine tone after the replacement of the uterus. So general anesthesia with inhalational agents is most preferred. Endotracheal intubation is mandatory in these cases. Invasive treatment for obstetric hemorrhage includes angiographic arterial embolization, balloon occlusion, surgical artery ligation, hysterectomy. Embolization is done under local anesthesia. Complications are very few. Preservation of fertility is very likely. Can be done in presence of coagulopathy. Requires rapid access to angiographic facility. Bilateral surgical ligation. Uterine, ovarian, and internal iliac arteries can be ligated. Preservation of fertility is there. Damage to other pelvic structures like ureter is a risk factor. Vascular anatomy is variable in depends on patients. Postpartum hysterectomy. This is the definitive treatment for postpartum hemorrhage. Tissues are edematous and congested. Amount of blood loss is more. Anesthetic management for postpartum hemorrhage. Obstetrician requires good skeletal muscle relaxation and quiet operative field. Regional anesthesia, there is risk of hypotension. The operative time for cesarean hysterectomy is more. Patient may have fatigue and restlessness. Intraperitoneal manipulation, dissection, and traction results in pain, nausea, and vomiting. Hyperemic pelvic viscera with engorged edematous vasculature require careful dissection facilitated by quiet operative field. If regional anesthesia is given, then maintenance of T4 sensory level is necessary. Prophylaxis against nausea and vomiting should be taken, and sometimes judicious sedation should be used. Most of the cases require general anesthesia for emergency obstetric hysterectomy. Regardless of anesthetic technique used, we should be ready with 2 large gauge intravenous catheters, at least 2 units of packed red blood cells, and additional units should be available without delay. Fluid warmer and establish invasive monitoring. There are recent advances in treatment of postpartum hemorrhage. Intraoperative cell salvage. thromboelastography, role of tranexamic acid and recombinant factor 7A. Thank you, sir.
Okay, that is a very exhaustive presentation you have made, but you have dealt mostly on the pathological conditions which are happening. Have you ever seen a major obstetric hemorrhage during this your training period?
No, sir.
No. Okay, you are lucky. See, the problem happens when you take up a patient for an elective or an emergency cesarean section. You give a regional block, which is the most recommended. You give a subarachnoid block with 2 ml of 0.5% heavy bupivacaine. Within 15-20 minutes, physician has delivered the baby, but the uterus is not contracting, starts pouring. What will you do?
Oxytocin.
I'm just asking for a practical purpose. Supposing you are doing it in a small nursing home, you are qualified, you have become, you have got your DNB, and you are you exposed to obstetric cases during this training period in
sir.
your hospital?
Yes, sir. Yes, sir.
Okay, right. So you are quite confident that you have handled at least 50 mothers for cesarean section. You have done a lot of spinals. So you are confident and you go to a small, which is your native place?
Maharashtra, sir. Aurangabad.
Okay, in Aurangabad, you go to a small nursing home at 2 a.m. in the morning. They call you because there is a fetal distress and you go and give a spinal. Surgery is over, baby is delivered, but uterus is not contracting. How soon the mother will become completely hypotensive and go into a shock, hemorrhagic shock? If the uterus is not contracting, maybe due to atony, or if it is a trauma, it is easy to repair that. But if it is an atony, there is no answer. After giving oxytocin, ergometrin, carbopras, all the pharmacological methods of trying to contract the uterus you have attempted, but still the uterus is not contracting. What is the time interval between the start of the bleeding and then the patient becoming severely hypotensive and go into a acute hemorrhagic shock? It may happen very soon, isn't it? Why it happens? Why you are so worried about this obstetric hemorrhage? Unlike your other trauma or other hemorrhages, we commonly talk about hemorrhage. How do you classify hemorrhage?
Sir, primary, secondary, and reactionary hemorrhage.
That is based on the time duration, but based on the volume of blood lost, how do you classify hemorrhage?
Sir,
It's classified into 4.
mild.
Grade 1, grade 2, grade 3, grade 4. Okay. So if
Yes,
you
sir.
lose only 500 ml, it is called grade 1. There will be practically no changes in the patient's hemodynamic status or consciousness or respiratory rate. 10,000 ml, some diastolic blood pressure will go up, systolic will still be normal. There may be a slight increase in heart rate. 1500 ml, you get a tachycardia, both systolic and diastolic blood pressure come down. There is a narrow pulse pressure, so pulse becomes little thready, and patient starts feeling little dizzy or little disoriented. And class 4, when 2000 ml is lost, patient is pale, ash-like, with peripheries are cold, and they lose their consciousness or become semi-conscious. Okay, so this is how you classify the grades: grade 1, grade 2, grade 3, based on the volume lost. Now, if the mother after delivery fails to contract the uterus and starts bleeding, how much time it will take for her to start from grade 1 hemorrhage to grade 4 hemorrhage?
Very less time.
Very short time. Why? Why it is within a very short time she will go into grade 4 stage? Because the uterus has got such a rich blood supply. and it has got no auto regulation. Okay, so it will start bleeding like mad. So patient will lose, because per minute the blood supply to the uterus is anywhere between 500 to 800 ml per minute. Okay, so if the uterus fails to contract, within no time the mother will be exsanguinated. She will lose all the blood. Okay? So what I would like to emphasize on this is, whenever you talk about obstetric hemorrhage, you can divide them into anticipated and unanticipated hemorrhage. Okay, because if you know that the patient has got a placenta previa, placenta preta, if you, because all these things can be found out by your ultrasonographic examination in the antenatal period itself. So you will be prepared when you know there is a abnormality in the uterus, or it is a twin pregnancy or a triplet pregnancy, or it is a polyhydramnios, the uterus is more than normal size and enlarged too much. You will anticipate that this lady might go into a postpartum hemorrhage or an intrapartum hemorrhage, and you will be all prepared. Whereas when you get caught in a normal pregnancy going for cesarean, and then the uterus not contracting and starts bleeding, that is the time you are caught, because you are doing it in a small nursing home. There is no blood bank facility. As you mentioned, keeping 2 units of packed red blood cell, packed red blood cell is not a routine for a normal emergency. There may not be a blood bank. Okay, so you must understand that if a patient starts to bleed, if there is an obstetric hemorrhage, you have to be doubly alert and vigilant, because in no time the mother can go into severe acute hemorrhagic shock. So how do you judge whether the patient is going in for that? If you are lucky, initially she may bleed about 1000 ml, and then the uterus may slowly start contracting. But if that does not happen, what are the clinical indicators of identifying whether she will go in for a major hemorrhage or not? What is obstetric shock index?
Hypotension.
Have you heard of that? Anybody listening to the class, can they answer this question? Obstetric shock index. How do you calculate that? Jay Bharati, Venkateswar Rao. It is nothing but the pulse rate divided by the systolic blood pressure of the patient. Okay. Normally, in a healthy patient, pulse rate will be 70 to 80. Systolic blood pressure will be 120. So you put the 70, 80 up, and then put the denominator systolic blood pressure. Okay. That ratio is always less than 1. Whereas what will happen when a patient starts bleeding? The first response is tachycardia. The blood pressure, the pulse rate goes up, and systolic blood pressure comes down. Okay. So the pulse rate divided by systolic pressure is what is called the shock index calculation. So another important thing in a mother is, they will compensate. The tachycardia comes in very, very late. By the time, if you are happy with the pulse rate of 70, 80, and suddenly she will jump to 130, 140 and collapse. So obstetric shock index is a very, very valuable tool to detect major hemorrhage at the earliest. Okay, so if the pulse rate starts going up, even if the BP is maintaining 120, 130, do not relax. That is the stage you have to be very watchful, order for blood. And second point, you said about massive transfusion with colloids and crystalloids. That point is now very much debated, because once the mother starts losing the blood, what is the danger of this traumatic or hemorrhagic shock? What is the pathophysiology in hemorrhage? What happens? What are all the chain of events that happen when a patient loses large volumes of blood? Not only a mother, any trauma patient or anybody, whenever they develop a huge hemorrhage, what are the sequelae or consequences of that loss of blood? What are all the things they lose? Your normal blood volume is 5 liters. Supposing you lose 1.5 liters or 2 liters, and you have only 3 liters left in your circulation.
Red blood cells patient will lose, and crystalloids and colloids will cause hemodialysis.
No. I'm not asking after the treatment. When as a patient loses blood, suffers from severe hemorrhage, what are all the changes that take place in the body? How does the body try to adapt? What is the first and foremost problem in losing blood and becoming acutely anemic?
RAS activations.
Huh?
Renin-angiotensin aldosterone activation system.
No, that is what is the basic thing. When you lose blood, what is the first function that is suffering in your body?
Decreased circulation, decreased perfusion, and circulation.
Oxygen carrying capacity.
Oxygen carrying
You
capacity.
lose your hemoglobin. Your tissues will not be able to get adequate oxygen. When there is no adequate oxygen, the carrier is not there, the postman is not there. When the postman is not there and not able to deliver oxygen, even if you are giving 100% FiO2, there is no postman, no carrier to deliver it to the tissues. So what will the tissues try to do? How will they maintain their metabolism?
Anaerobic metabolisms.
They will go for anaerobic metabolism. This anaerobic metabolism, what will it do?
Lactic acidosis.
It will accumulate lactic acid. This lactic acid, what will it do to the pH?
Reduce residue
It will
metabolic
reduce the
stress.
pH and make acidosis come in. When acidosis comes in, what will happen?
Enzymatic
All the
enzymes will
be suppressed, including
reduced.
your catecholamines. Okay, that is how you go into this vicious cycle of shock. So, if you keep on pumping crystalloids and colloids, what are you doing? In a patient who has been receiving 800 ml of blood per minute to the uterus, starts bleeding, and she loses within say 2 minutes or 5 minutes or 10 minutes about 1.5 liters of blood. There is no time for you to replace or do that. She will go in for severe acidosis, and once acidosis sets in, it is a case of non-return. We cannot retrieve that patient. So instead of pumping too much of crystalloids or colloids, you must try to get the compatible blood as early as possible. And that blood, packed red blood cells, do they contain WBCs also? The PRBCs that we normally give, do they contain WBCs or not?
Yes.
They do have WBCs also, but we don't require WBCs here. So it is preferable to have leukocyte reduced or leukocyte irradiated packed red blood cells, so that you will give concentrated red blood cells alone, which will be helping to carry the oxygen to the tissues and prevent the conversion of aerobic metabolism into anaerobic metabolism. So the goals that we want to keep in mind for treating an obstetric hemorrhage is not just blindly giving IV fluids rapidly. You must ask for blood as early as possible, and once you start treating it correctly at the earliest with adequate amount of blood, there the hematocrit should be at least 30%. That is 10 grams of hemoglobin should be maintained. So you must monitor the hematocrit and hemoglobin whenever you are trying to treat a patient with major obstetric hemorrhage. Number one. Number two, you must measure the serum calcium level, because when you give too much of blood, what will happen? Supposing you transfuse 10 bottles because the lady is bleeding profusely. If you don't care to check the calcium, what can happen? How is the blood kept prevented from clotting when it is in the bag, when it is stored?
Citrated blood, sir.
Citrate is added. So that citrate
Added
will
calcium
exhaust all
citrate.
your calcium stores. So if you don't take care of the calcium, that will continue to prevent the normal coagulation, and that will cause more bleeding. Then patient will become hypothermic or hyperthermic.
Hypothermic.
hypothermia will happen. So hypothermia will further aggravate coagulation process, and that will also lead to more bleeding. Okay, so these are all the vicious pathophysiological changes which has to be explained when you are talking about obstetric hemorrhage. I don't say that you should not talk about placenta antepartum, placenta previa, um, heteramnias, and all those things. They are all obstetric conditions which can lead to that. But more importantly, you must give a detailed description of why obstetric hemorrhage is such a dangerous thing which can kill a patient, leading to mortality because of the rapid nature with which the blood can be lost. And if it is not corrected in time, it can lead to an irreversible state of shock and patient may go in for mortality. So that is the reason why we are always worried about. And there is a lot of difference between doing such cases in a well-equipped institution and an institution like a small nursing home where there are no facilities. So why I ask this question is, if you happen to come across such a clinical scenario where the uterus is not contracting and the woman is bleeding, her pulse rate, which was 70 to 80 intraoperatively, now starts rising, goes to 110, 120. Do not try to resuscitate that patient in that nursing home. Continue the resuscitation and transfer to a major institution where blood bank facilities and adequate blood are available at the earliest, so that, because majority of the litigations that happen happen because they try to resuscitate the patient asking for blood from a blood bank which is about 4 kilometers, 10 kilometers away, and they come and ask for grouping, cross matching, and all that. So the delay in the restitution of the blood volume is a major cause of morbidity and mortality. That is the point I want to insist, so that as beginners, you will have to be very watchful in case there is a bleeding. Majority of the times, 95% of the times, everything goes smooth. You give a spinal, baby is delivered, placenta is delivered, uterus nicely contracts, physician is happy, and sometimes even before the last suture is made, you say bye bye, take your fees and go away. But 5% of the time that will not happen. When such unforeseen complication happens, that is the time you must be. For this only, they say you have to go through what is called the major obstetric hemorrhage drill, so that you will be tuned to that and you will be able to manage that condition if it is happens even very rarely. Okay, so that is first thing. Unanticipated, just like your anticipated airway and unanticipated difficult airway, I think you all should know when to anticipate a obstetric hemorrhage and when to. Sometimes you will be taken by surprise. In a normal healthy case also, this complication may happen. The second thing is, you must know whether the patient had any epidural placed, either for labor analgesia as a routine in some institutions or for some purpose. If already a labor analgesia or an epidural catheter is there, it makes a lot of difference between a patient who has got no labor epidural and a patient coming straight for the first time cesarean or a delivery. Either even vaginal deliveries can sometimes bleed. So that is the second point that you have to keep in mind. The third point is whether to give spinal or GA when you have a known anticipated problem. For example, if the patient has got a placenta previa, how will you decide whether you want to give a spinal or you want to give a GA?
If placenta previa presents without bleeding, without active bleeding, then we can give neuroaxial blockade.
Very good, very good. Okay. Supposing it is at the margin, it is neither too deep inside or it is neither completely covering. So it is partly encroaching on the delivery canal, the cervical outlet. In that case, what will you do? How would you decide whether you can give a regional or whether you want to give a GA? See, here you can anticipate some amount of bleeding. Okay,
Yes.
When the head comes down, it may press on the placenta and avoid bleeding also. When it is partly encroaching into the cervical canal, it may not bleed that much. But whenever you decide on regional, what is one important point you must make sure? That you will have no difficulty with the airway. You must assess the airway thoroughly, because you may need to convert it to general anesthesia at any point of time. So if you are planning to give a regional for a anticipated or a known antepartum complication which is likely to result in a obstetric hemorrhage, always make sure that you have a easily manageable airway which can be converted to general anesthesia with endotracheal intubation without any trouble. If that is the case, then you can boldly give a regional, and at any point of time, if it is getting prolonged or if the bleeding is very severe and patient starts losing a little bit of sensorium, then you can immediately convert it into general anesthesia. Okay, so that is the important practical point all of you should remember, that never fail to assess the airway just because you are giving a regional for a patient with anticipated or unanticipated major obstetric hemorrhage. Okay, so these are all the points, and you have to you just made a passing mention of the recent advances. It is not recent advances, it has become almost part of the routine management in majority of the institutions, where thromboelastography is used to assess so that you can give the correct blood products. So usage of blood products to enhance the coagulation is very, very important. And of that, you must mention fibrinogen. One of the important goals that we have to achieve is we must have a fibrinogen level of more than 250 milligram per deciliter. Otherwise, what will happen? All the fibrinogen is used up, and whatever blood you are giving is not having any coagulant factors. So patient will continue to bleed. You will be pumping blood in one side, and she will lose all that in the other end, and you will end up with no success. So the majority of the patients are deficient in fibrinogen. So major obstetric hemorrhage patients should have replacement of fibrinogen in the form of either a fibrinogen concentrate, or FFP and cryo also have some amount of fibrinogen available. So if you cannot get a concentrate of a fibrinogen, you must try to replace it with FFP and cryo. The advantage of giving fibrinogen concentrate is the volume is less, so you will not land up with overloading. Whereas if you give too much of FFP and cryo, you may be landing up with overloading in the circulation also. Okay, so these are all some of the points which are given in the recent textbooks and recent advances, which may be expected because you are all DNB students, so you are supposed to know all these points. So with that, do we have time to share the slides, Amache?
Yes, please, sir. Yes, please, sir.
Okay.